Well, thank you everyone for joining us today for our event titled Mental Health During Perinatal Period, Helpful Strategies for Community Members and Practitioners. For your information, all participants' microphones are muted today. And if you have any question, we ask you to please use the Q&A box that is located in the bottom center of your Zoom Windows taskbar. The chat box is also available if you have any comments or technical support questions during the presentation. As a reminder, this webinar is being recorded. The recording will be available on Saskatchewan Prevention Institute's website and will be emailed to you in the coming days. My name is Rashmi Tandukar Bhaukaji. I am the Perinatal and Infant Health Program Coordinator with the Saskatchewan Prevention Institute. The Saskatchewan Prevention Institute is a provincial organization. Saskatchewan is located on treaty lands 2, 4, 5, 6, 8, and 10, and the traditional lands of the Métis. We acknowledge that our work is carried out on and with the people from these lands. We are committed to working towards reconciliation and strive to reaffirm our relationship with one another. Our organizational focus is to help all children thrive through primary prevention and the promotion of well-being. We believe that all children, regardless of ability, have the right to the best physical, social, and emotional health possible. We provide education, training, and capacity building across a variety of areas, including early childhood mental health, fetal alcohol spectrum disorder prevention, child injury prevention, child traffic safety, parenting education, sexual and reproductive health, and perinatal and infant health. So one of the focuses of perinatal and infant health, or PIH program, is to provide evidence-based information on topics related to mental health before, during, and after pregnancy that is accessible to the healthcare and service providers working with pregnant people and mothers. So as we know, maintaining mental health is important to the well-being of pregnant and postpartum individuals, as well as to their children and families. A crucial window for intervention is the perinatal period. Sadly, the pandemic has only widened the already existing gaps in the mental health services, making it highly important to ensure that families have access to prompt, efficient, and accessible mental health care. Today, we will explore the effects of poor mental health on pregnant people and mothers, the fetus, the newborns, and the significance of mental health care before, during, and after pregnancy. We will also look at the ways to support communities and practitioners in recognizing those who may be experiencing mental health issues while pregnant or after giving birth, evaluating the severity of their symptoms, and choosing the best course of action, including follow-up care. Here to speak on this topic today, we have Jamie Charlebois. Jamie is an advanced practice nurse and psychotherapist with over 20 years of experience in the perinatal field. She has been active in many different roles, including academia, leadership, and advocacy positions, and has significantly contributed to scholarly output. In her current role as Regional Perinatal Mood Disorder Coordinator at Aurelia Soldiers Memorial Hospital, she connects families, primary care providers, and community agencies and organizations to perinatal mental health services and supports, along with providing specialized psychotherapy to perinatal families. As co-founder and co-executive director of the Canadian Perinatal Mental Health Collaborative, Jamie informs perinatal mental health policy both at the federal and provincial levels, and lobbies the federal government to improve access to perinatal mental health services across Canada. Now, without further delay, let's welcome Jamie.
Thank you, everyone. Thank you for the warm introduction. Today, I'm going to be sharing my slides through a new platform, and I'm hoping that everything goes off without a hitch. I know that doesn't always happen, but let's see how it goes. Okay, so hopefully everyone can see my slides. Today, I'm going to be talking about mental health during the perinatal period, helpful strategies for community members and practitioners. I'm grateful to live and work on the traditional territory of the Anishinaabe. The Anishinaabe, including the Ojibwe, Ottawa, and Potawatomi nations, collectively known as the Three Fires Confederacy. Some people experience pregnancy, birth, and parenting, and some who seek perinatal care, including mental health care, do not identify as mom or mother. Some people who experience pregnancy and birth do not identify as cisgender women or use the pronoun she, her. Recognizing the diversity of gender identities and expression, we commit to making improvements in the use of gender neutral or gender inclusive language. At the same time, we acknowledge that mother and women are terms used when referencing studies that involved mothers and women as participants, or when directly quoting survey participants or people with lived experience who themselves use these terms. In addition, many dads and partners are suffering in silence, largely due to stigma and not accessing needed treatments. This is a problem that also needs to be addressed. It is vital that in our effort to improve perinatal mental health across Canada, that we are inclusive with regard to sexual and gender identity, and to those who experience marginalization and oppression, such as peoples with disability, Black, Indigenous, and people of color. I believe the learning objectives were already kind of spoken about, but I have been asked to provide around a 60-minute presentation with about 30 minutes of Q&A at the end. As healthcare professionals, it is crucial to understand the importance of perinatal mental health and to take steps to support people who may be struggling. Today, we will explore the impact of perinatal mental health disorders, the signs and symptoms to look out for, and the importance of taking a proactive and collaborative approach to supporting people during pregnancy and postpartum. Before I jump into the perinatal mental health aspect, I want to discuss current parenting culture and how this is contributing to growing rates of perinatal mental illness and impossible parenting dynamics. So here's a recent headline that was published a couple months ago in Motherly, talking about the complexity of parenting and how it has become so difficult in the recent years. And it's a truth as old as time. Every generation of parents will have unique struggles due to social, economic, and political contexts. Mothering through the ages has been celebrated. Other times it has been denounced. In the late Victorian period, motherhood was revered as a crucial role and legitimate full-time position, raising the next generation of moral citizens. But what is clear is that a major shift has occurred for parents around expectations. And it really is a standard that is almost unattainable. The bar is simply set way too high. We are marked in an era with a rise of intensive mothering, an ideology that sets out ideals, norms, and practices for being a good mom. And the good mom is expected to be self-sacrificing, wholly centered on her child, endlessly patient, financially and emotionally secure, and consumed with the task of motherhood. And we also can't deny that today's fathers or partners have started to take on roles vastly different from previous generations, and we are forever thankful for this. And while popular culture portrays the new father over the past 2 decades as more involved, more nurturing, and capable of co-parenting, many argue that actual fathering conduct has not kept pace. And unfortunately, what is true for today is sexism still exists within current parenting culture, and a major societal shift needs to occur. In a year-long study of Canadian culture of fatherhood, findings suggested that through representations of parental guilt, parental responsibility, and work, family balance issues, and hegemonic masculinity, mothers continue to be positioned as primary parents. And support for father involvement, to the extent that it exists, occurs within a framework of fathers as part-time secondary parents whose relationship with children remains less important than mothers. Have I stirred the pot enough? Also wanted to talk about this concept that I learned about from Dr. Bruce Perry, who is a renowned child psychiatrist. He talked about alloparenting and said that for thousands of generations, we have lived in small multi-family groups of around 40 to 60 people. And alloparenting was the norm, with caregiving ratios of 4 adults to 1 child, not the opposite. Okay, so the human brain and the way that it is designed is not for the modern world, because we have, in a more individualistic culture, determined that one-on-one, 1 parent to 1 child is considered the norm and an attainable goal, which we know by the people that we serve and the people that we support that this ratio is problematic. And the human brain is just not designed for this. Alloparents are people who are not parents to your children, but who help raise them in varied ways, are a big help to families, and can improve child outcomes. So this is kind of the concept that we talk a lot about, the creating a village, or the village of support, where we wrap around families and we come together and we raise children in a more collectivistic way. And in the words of Dr. Bruce Perry, society has created an unsustainable model for parenting. And I hear this quite frequently in my patient sessions about how the bar is just set so high, and what we're currently asking parents to do is just too much. So I want to switch gears now into the perinatal mental health content. So far from being protective, the perinatal period, which we call from surrounding conception to about 12 months post-birth and sometimes beyond, is a time when there is an increased risk of psychiatric episodes. This period of the lifespan brings normal emotional ups and downs that we call the baby blues, but depression and anxiety are not considered normal in this time period. Despite this vulnerable time, most people are motivated to have healthy pregnancies and to be the best parents that they can be. And we see this as a window of opportunity to address concerns. But we know that perinatal mental health disorders have a significant impact on a mother or birthing person's health and well-being. The one thing that is true is that perinatal mental health disorders don't discriminate. It doesn't matter your color, your culture, your race, your socioeconomic status. The risk is there, and definitely there are situations where the risk is increased. We also see a spectrum of illnesses that occur across the perinatal period, and they range from mild to emergency. And we'll talk a little bit more about that in a bit. And then you might have also heard that across the perinatal time period for healthcare practitioners, we look at a biopsychosocial treatment model, which looks at the biological components of mental illness. So whether this is because of a family history, which does increase the risk by 33%, or having previous perinatal mental illness, which increases the risk by about 65%, or a psychological component, so like a genetic impact. Sorry, biological, I should have said, is more hormonal impacts. And then the social piece, the environmental factors that are going to impact our mental health. And perinatal mental health disorders affect about 20% of pregnant and postpartum people, or about 80,000 Canadians per year. But only 15% of affected Canadians are receiving evidence-based treatments that are known to help them thrive. Of those who do receive help. More than 40% report waiting more than 2 months for specialized services, and we know that number is significantly higher. Canadians who are low income, immigrant, 2S LGBTQIA+, Black, Indigenous, or persons of color, and those who live in outside urban centers have the lowest treatment rates. People experiencing perinatal mental health disorders are at a risk of experiencing a range of negative outcomes. So that can be difficulties with bonding or attachment to the baby, reduced breast or chest feeding rates, poor infant health outcomes, increased risk of suicide, so that's about at 5%, or infanticide at rates of 4%, and reduced quality of life. And given the potential consequences of untreated perinatal mental health disorders, it is essential that healthcare professionals are aware of the signs and symptoms to look out for and take a proactive approach to supporting women during pregnancy and postpartum. There are many signs and symptoms that healthcare practitioners should be aware of when it comes to perinatal mental health disorders. And these can include excessive worry or fear, so basic anxiety symptoms, feeling sad or hopeless are depressive symptoms, anhedonia or a lack of interest in activities that were previously enjoyed, difficulty sleeping or changes in appetite, difficulty concentrating, so there's like this brain fog, feeling irritable or angry or rageful, which is a symptom that we're talking more and more about. And then thoughts of harming oneself or the baby, and we'll be talking about that in more detail. This is my pet peeve alert. I hear in the community a lot, it's like, I got postpartum, or I've got the postpartum, and I'm always like, my goodness, the postpartum is a time period, it's not a thing. An interesting fact, though, is that 50% of postpartum depression actually starts in pregnancy and is undetected or overlooked as a symptom of discomfort. And we hear postpartum depression more often, but we know it can happen at any time across the perinatal period. So I'm just going to give a little bit of information about each of these disorders. So postpartum mental health disorders encompass a range of conditions that can affect people following or during childbirth and beyond, While postpartum depression is the most well-known, there are other lesser-known disorders that have a significant impact on the lives of new parents. So perinatal anxiety can affect around 10% of new parents. We know that this rate definitely has increased during COVID and beyond. And it goes undiagnosed due to the focus on postpartum depression. Symptoms include constant worry, racing thoughts, and feelings of dread. And sometimes the physical symptoms of dizziness, rapid heart rate, and difficulty breathing. With postpartum OCD, this affects about 3 to 5% of new parents, and it's characterized by intrusive and obsessional thoughts about the baby, often involving harm. And these quite frequently are thoughts involving knives, driving, or stairs. And people with OCD may experience compulsive behaviors such as excessive cleaning or repeating and checking on the baby, which can interfere with their daily functioning and bonding. One of the pieces I really wanted to talk about in regards to intrusive thoughts is that intrusive thoughts happen in almost every postpartum journey. And people will have these thoughts and they're very dysregulating, and they can pop in your mind like popcorn or an automatic thought, or it can play over and over like a video loop. And the reassuring thing for healthcare providers is that intrusive thoughts are normal, that they make the person feel bad. They feel guilty about it. And the risk of them acting on these thoughts are very low. And this is different than psychotic thoughts where people are not in touch with reality, where they don't know the thoughts are wrong and that their chance of acting on them, the risk increases. Okay, so that is a very important piece to be able to distinguish. In regards to eating disorders, they're quite common and serious conditions affecting around 5 to 8% of pregnant people, and is one of the deadliest of the mental illnesses. New parents with a history of bulimia or binge eating disorders are also 3 times more likely to experience postpartum depression. Bipolar disorders that occur are characterized by extreme mood swings or episodes of mania and depression. The onset can be triggered by hormonal changes and sleep deprivation. So they are highly susceptible to sleep deprivation. This condition can be underdiagnosed as its symptoms can overlap with postpartum depression and psychosis. An interesting factoid, 50% of women with bipolar disorder were actually diagnosed in the postpartum period. PTSD can develop after a traumatic childbirth experience, such as an emergency C-section, difficult labor, or the baby needing to be admitted to the NICU. With changes in the DSM-5 diagnostic criteria with PTSD, we know that trauma is in the eye of the beholder. And so if a person perceived their birth to be traumatic, it's important for healthcare providers to listen, to support, and to help them get the treatment that they need to process their birth experience. Symptoms of PTSD include flashbacks, nightmares, avoidance of the reminders of the traumatic event, and it's estimated that about 1 to 6% of people will experience this after childbirth. And a lot of recent research is actually speculating that that number is significantly higher. Postpartum psychosis is a mental health emergency occurring in 1 to 2 out of every 1,000 births, and typically occurs within the first 2 to 4 weeks after birth. This condition affects a person's sense of reality, causes hallucinations, delusions, or paranoia, and other behavioral changes, and it waxes and wanes. So people can come in and out of the presentation, which makes it really difficult for family and healthcare providers to recognize and diagnose. In severe cases, people with postpartum psychosis may attempt to harm themselves or the newborn. This condition is highly treatable, and with early detection increases the odds of good outcomes. Now I have a video, so I'm going to stop sharing and then play my video, if I can find it. Hold on a second. I need to go to my other window. I don't know if that's going to work. One second. Okay, hold on.
Something was wrong, but I didn't know what. Every day, she became more distant from me and really never looked at the baby. And when she did look at the baby, she told me that the baby hated her. She said, "Oh, Mommy, I'm such a bad mother." She said the baby doesn't deserve to have a mother as bad as I am. She just seemed to have gone into a whole new world, all her own. It was like a monster had entered her body, you know. It was like, I'm telling you, I have never seen anything like it in my life. She got a cab. She went downtown, she checked in a hotel, and she went up to the 12th floor and she jumped out of a window. And she left her brand new baby that she never got to enjoy. She left me and broke my heart. But it also made me extremely angry. And I thought, I've got to do something. I can't let this murderer kill my daughter and I not try to go after it. I can't have something called postpartum psychosis take my wonderful daughter from me. I had no idea how deadly it was. And I've done everything that I can to expose this monster, but I haven't done enough because women are still in prison and women are still committing suicide under the influence of postpartum psychosis and harming their babies.
Okay, so hopefully my slides have switched over. That was a video from Postpartum Support International, done several years ago. And I just felt it was really important, especially after many recent events that have occurred across Canada and the United States, that we all have a very clear idea of postpartum psychosis, that it is an emergency, but that if we intervene early, we can have a positive impact on the outcome for these families.
Sorry to interrupt you, Jamie. We can see your notes as well.
You can see my notes. Okay. Hold on a sec. So you guys need that. There. Are you guys not seeing my notes anymore?
Anymore. Thank you.
Okay, perfect. If you leave knowing one thing, and maybe you know this already, it's really important for us to know that perinatal mental health disorders are the #1 medical complication during pregnancy and postpartum. And that perinatal mental health disorders are occurring at rates 2 times higher than gestational diabetes and gestational hypertension. Yet in Canada, we have no clinical practice guidelines or standards of care to assist and direct our healthcare professionals in the assessment, diagnosis, and treatment of perinatal mental health disorders. Now it's coming. We have clinical practice guidelines that are being worked on by the Society of Obstetricians and Gynecologists of Canada. The federal government just funded standards of care to be started looking from the psychiatric standpoint, the CANMAT guidelines being done by Dr. Simone Vigod and Dr. Benicio Fry from Women's College and McMaster University. And this could all be rectified by having a national perinatal mental health strategy. So these clinical practice guidelines and standards of care are components of a national strategy that is seen in other countries such as Australia, the UK, and different parts of the US. Unfortunately, there are consequences when untreated. Perinatal mental health disorders can negatively impact an affected person's well-being and their health and development of the children and families, making perinatal mental health disorders a major public health priority. We need every healthcare professional to take a proactive approach to supporting people during pregnancy and postpartum. So in a room with professionals that have firsthand experience with mothers, infants, and children, you know what adverse childhood experiences are, or ACEs. And and the range of traumatic events that can occur before a child reaches the age of 18. But did you know that maternal mental health is the first ACE, which then cascades into physical and mental illness in the child and family for generations, playing a role in the perinatal physical health outcomes of both mom, birthing person, and their babies. A quick second is parental mental health. It has been proposed that not only have adverse childhood experiences have a profound effect on the lifetime trajectory of our offspring, but they can put women and birthing people at risk for mental illness in the pregnancy and postpartum periods also. And the most tragic consequence is maternal suicide, as we witnessed last year with the death of Flora Babakani, a Toronto mom by choice who experienced undiagnosed and untreated postpartum psychosis after the birth of her very wanted baby, Amber. One of the biggest concerns is the epigenetic transmission of maternal mental illness from parent to offspring, with hypothesized prenatal and postnatal pathways leading to risk for childhood depression. The fetus is exposed to the mother or birthing person's depression in the intrauterine environment via placental transfer of changes or altered levels of hormones and neurotransmitters, specifically elevated circulating cortisol, norepinephrine, and decreased serotonin levels. This can lead to an increased risk of stillbirth, premature birth, low birth weight, low APGAR scores, smaller head circumference, and major congenital abnormalities. And the risks of untreated mental illness can include compromised prenatal care, inadequate nutrition and weight gain, increased risk of obstetrical complications, self-medication or substance use, compromised mother-infant interactions, and increased infant and maternal mortality. And the last one is being explored currently by the SOGC. 3% of Canadian mothers who recently gave birth reported using cannabis during pregnancy and while breastfeeding in a 2018 study. The dangers of substance use are concerning, as 13% of pregnant Canadian women surveyed reported past month cigarette smoking, 11% reported past month alcohol consumption, and 5% reported using drugs while pregnant. People might be hesitant to seek treatment because of intense stigma that exists around substance use, especially while pregnant. And thus, substance use during pregnancy is a complex issue requiring multifaceted programming and policy responses. Adversity in childhood is known to have impacts on behavior, physical and mental health, educational achievement, and social and health realities throughout the lifespan. Children whose mother or birthing person have perinatal mental health disorders have been shown to have an increase in multiple health issues, including internalizing and externalizing behaviors, and emotional difficulties such as violence and conduct disorder. And just a little food for thought, you know, a question that many of you might have or have experienced is, you know, what happened in our healthcare system when the attention to already vulnerable people, perinatal families, when we pulled services away during the pandemic? The impact on their mental health long-term has yet to be seen. And yet we know that rates of depression through COVID doubled and rates of anxiety tripled. And our children have experienced isolation along with their parents. And what we asked parents to do during COVID, I just can't even imagine. I have an 18-year-old almost, but when I was working from home and my child was homeschooling she was quite independent. My friends with younger children who had to work from home and homeschool their children and do all of the other things, it was just, my goodness, so much to ask of these families. And the COVID-19 pandemic had and continues to have a significant impact on the perinatal period and the mental health and well-being of people that were studied. We know has had an impact on the way that they parented and on their children's outcomes moving forward. So switching gears, I wanted to talk more about what's occurring provincially. So in your province of Saskatchewan, what's occurring across Canada and what the next steps are in regards to perinatal mental health. So first of all, I'd like to preface that the work done by your provincial champions to date, you all know who they are, has really set the bar for other provinces and territories across Canada. Although many great services and programs exist, gaps in those services and barriers to care still persist. And we also know that this continues to be a work in progress until we receive prioritized and sustainable federal and provincial funding, with the goal of unifying our voices and creating common language. And now with mental health screening, we need a streamlined and stepped care approach to match the level of need of pregnant and postpartum people to appropriate mental health services. We need a best practice approach, which is standardized for frontline providers to determine what their patients might need, what their clients might need, and where to direct them for timely, which is important, timely access to appropriate perinatal mental health care. In the fall of 2020, with REB approval from the University of Calgary, the Canadian Perinatal Mental Health Collaborative and our research partners launched a first-of-its-kind national perinatal mental health survey of healthcare providers. With close to 500 responses, the results confirmed what many of us already know, that 87% of our healthcare providers report not having mandated screening for perinatal mental health disorders in their workplace. And 57% reported that they do not have specialized training in perinatal mental illness. In the summer of 2022, the Canadian Task Force for Preventative Health Care published a position against instrument-based screening for perinatal depression in the Canadian Medical Association Journal. Now, obviously, we weren't too excited about that publication and the recommendations. And so we published a rebuttal with over 50 individual and organizational stakeholders and supporters, stating that we appreciate that the Canadian Preventative Task Force has highlighted the important topic of instrument-based screening in perinatal mental health, but we disagree with methods and conclusions of their review. And we aim to call attention to the critical importance of increasing screening, assessment, and treatment of mental health needs, and move towards our shared goal of supporting families and birthing individuals. So looking from a proactive and collaborative approach to supporting perinatal families, we need our healthcare practitioners to use validated screening tools such as the EPDS, the PHQ-9, the GAD-7, and identify people who may be at risk of perinatal mental health disorders, because you cannot tell by looking at someone. People in the perinatal period have a mask of functionality and can tell a good story. And we really need to be providing a supportive therapeutic environment, a holding space, so that our clients feel comfortable and trust us to talk about the struggles that they are having. Screening should take place during pregnancy and at regular intervals throughout the first year postpartum. And luckily in Saskatchewan, you have those touch points already established. Healthcare practitioners should provide education and support to people to help them understand the changes that they may be experiencing during pregnancy and postpartum. This education should include information about signs and symptoms of perinatal mental health disorders and the importance of seeking support if they are experiencing any of those symptoms. If a person is identified at being at risk of maternal or perinatal mental health disorders, healthcare practitioners should refer them to specialized support services. These services may include psychological therapies, medication, or support groups. So really knowing who's in the community, who are your doulas, your early childhood educators at the early on and child family centers, your social workers, psychologists, psychiatrists, your nurses, who has the evidence-based training and information to refer to. So really also looking at perinatal providers too, so like our pelvic floor physiotherapists, our massage therapists, OTs, RTs, people that are supporting these clients and people within the community, but not within a hospital or a healthcare environment, because our clients are accessing support from these individuals more and more frequently. Healthcare practitioners should work collaboratively with other professionals involved in the care of women, including obstetricians, midwives, and mental health professionals. This collaboration ensures that people receive coordinated wraparound care that is tailored to their individual needs. And healthcare practitioners should encourage people to prioritize self-care during pregnancy and postpartum. So this includes activities such as exercise, eating a healthy and balanced diet, and getting enough sleep. So what do we do now? We have all of this information, we have these services and programs, but how do we put it all together to create this timely access to care? So on July 22nd, the Daymark Foundation worked on stepped care solutions, convening an initial group of 18 stakeholders for a discussion on how to optimize and operationalize stepped care approaches in perinatal mental health context. The Daymark Foundation is located in Toronto and has prioritized perinatal mental health and bipolar mood disorders through their foundation and the work that they are prioritizing. The participants from this stakeholder group each provided a unique perspective on perinatal mental health and related issues. Together, the group explored ways to build upon existing assets and touch points across the perinatal journey with the goal of producing a more holistic framework for organizing perinatal mental health and well-being supports. This model reflects the basic notion of stepped care, which did come from the UK and is hugely enjoyed by our Minister of Mental Health and Addiction, Carolyn Bennett. And the notion of stepped care is that people do not necessarily need the most formal, scarce, and costly services available. And this is depicted on the left using a color gradient to represent the increasing level of intensity. It also acknowledges that readiness and trust are major influencers of the types of support a person will access regardless of their perceived need. The model also added 3 new components to the stepped care model with information, social networks, and care. So knowing that people are accessing information in different ways than they used to. One of the biggest things, and I say this to my clients all the time, is that when I, started my motherhood journey, there was no internet the way that it exists today. I couldn't jump on Google and find a plethora of information, whether correct or incorrect. That would change the viewpoint of how I would parent. But now the people that we are supporting have all this information at the click of a button, and it can be very devastating on their mental health. Also, the comparisons that social media creates between different people, perceptions of what their life is on the outside, and that everything fits in this neat little package. Going deeper into this, looking at key strategies for advancing a holistic stepped care model for perinatal mental health is integrating upstream components into the perinatal mental health stepped care spectrum, which will enable a more kind of seamless connection between mental health promotion and mental health care. And some key strategies to achieve this integration include normalizing mental health, because there is a growing recognition that mental health is part of overall health. We know that there's no health without mental health. And rather than addressing mental health in a silo, there is value in bringing a mental health lens to all aspects of perinatal experiences. So this can include moving to a model that recognizes mental health instead of mental illness, to one that recognizes kind of the fluidity of mental health throughout the perinatal journey. Reducing stigma around perinatal mental health by raising awareness about the prevalence of mental health issues and the inherent challenges that being pregnant or new parents, and integrating mental health content into all pregnancy and new parenting materials. Also building the capacity of our providers and supporters. We know that perinatal mental health is not in the curriculum of our physicians and is not in a robust way in many other healthcare provider curriculum. So we need to be advocating that it is embedded into the curriculum so people are graduating and starting to practice with a basis of knowledge. And part of the reason why mental health is not addressed outside of targeted settings is because carers and providers don't always feel equipped to provide the right support. Building capacity for those that surround perinatal people to address mental health within the scope of their role can serve to operationalize a stepped care approach. So really looking at who can intervene in the mild to moderate phase and who needs to be accessed during the more serious or emergency situations. So looking at informal supporters that fall within social networks, components could be educated on the basis of mental health and how to comfort someone. For example, helpful versus unhelpful resources. Care providers in the care component could be guided on how to ask about mental health, respond to somebody in distress, and refer to higher intensity services. Primary care providers such as OBGYNs, midwives, family doctors, and nurses should be trained in how to detect and address perinatal mental health concerns. And task shifting approaches can enable non-specialist providers, the ones without all of the training and education, to deliver brief mental health interventions such as CBT or behavioral activation, which is being studied right now in the Summit trial being led by 3 different sites, U of T, UNC Chapel Hill, and a Chicago site. And this is the biggest psychotherapy, perinatal mental health psychotherapy trial in the world. Also recognizing the contributors to mental health. So most people in a women or birthing person's everyday life wouldn't see themselves as providing mental health support, but often just being there for someone goes a long way to promoting well-being. So providing reassurance, validating people's feelings and thoughts, letting them know that a lot of what they're going through is normal and that with help they will be well. In some cases, the root of poor mental health may be a particular source of stress that could be addressed by care providers or support people. Acknowledging that social determinants of health that may be causing distress, such as housing, food insecurity, income instability, or family violence, and addressing aspects of new parenthood that could be challenging, providing support to new parents in feeding, sleeping, older children's care, and other stressors can help promote well-being. Also, leveraging existing place-based opportunities. So understanding that perinatal people have multiple interactions and touch points throughout their journey. Many say that there's never a time that we will interact with more healthcare professionals than from conception to 1 year postpartum. And if that is the case, somebody should be picking up on these struggles. And we have a lot of chance to educate and to provide support and really increase significant interactions. So looking at physical spaces to help raise that awareness. So whether it's in our early on child and family centers, the public health units, within the hospitals, within primary care offices, making sure that there's posters and pamphlets and other educational material that could signal people to think about their mental health and motivate them to adopt health promoting behaviors and or seeking help. And then virtual spaces, making sure that we are promoting podcasts, online groups, websites that might be providing or sharing short messages or talks about providing or assisting in mental health across the perinatal time period and how to promote positive well-being. And the last is taking an equity and diversity lens. Knowing that perinatal people are not a homogeneous group. Operationalizing a stepped care approach means recognizing the unique context, barriers, norms, and expectations of equity-seeking groups and designing with these in mind. So recognizing the role of systemic racism against BIPOC communities and its impacts on mental health. Acknowledging a perinatal person's family of choice and the role they may have in supporting their mental health. Using a gender inclusive and racially diverse language and images in all printed materials. Supporting mental health through cultural teaching, connections to elders and care providers that share one's identity. Recognizing the value of doulas as cultural interpreters, advocates, and support people for those who experience systemic discrimination. And understanding who is showing up for formal mental health services and supports and who isn't. And using this data to design more inclusive supports, conduct proactive outreach, and meet people where they are at. So kind of creating the every door is the right door approach. And acknowledging that cultural norms and systemic racism may prevent some people from disclosing their mental health concerns and designing inquiry and assessment approaches and responses with these factors in mind. So this is all from the report that the Daymark Foundation printed. The link is on the following slide. So please feel free to go and look. It's a 29-page report. And it was wonderful to be part of the process and meet with such amazing practitioners across many different fields of holistic and medical care. I also, wanted to talk about sometimes, and this came up in a meeting I was in the other day, is that sometimes we have to challenge the status quo. Keeping in mind that challenging status quo doesn't mean that we have to, that something isn't operating well or that something needs to change. People often have the idea that something has to be wrong before suggesting improvements. Sometimes challenging the status quo is simply proposing a new idea that may be worth exploring. Perhaps it's already great, and is there a way that we can improve it or make it better? So just looking at this from a change culture lens, number one, we can challenge the status quo by inviting all perspectives. To do so, we must examine issues and be thoughtful about whose perspectives can really lend a fresh new point of view. The goal should be to get the people who are affected by specific policies and training in the room. We can also invite more questions and take this opportunity to get curious and to be curious. Maybe a major overhaul isn't what's in order, and it just takes a simple adjustment or tweak that can make everything or everyone more engaged. And lastly, we have to be ready to help the change. Consider all the variables, including the resources you may have available to implement the new ideas, or explore all avenues that you can to make a positive change possible. So just switching gears here as I'm getting close to the end of my presentation, I wanted to talk to you a little bit about the Canadian Perinatal Mental Health Collaborative. And this was formed by myself and my business partner, Patricia Tomasi. We are both people of lived experience of perinatal mental illness. And the CPMHC is a federally registered nonprofit organization. Our mission is to improve perinatal mental health care with the focus on working with all levels of government to create a national perinatal mental health strategy that will provide direction, policy, and funding for improvements to perinatal mental health care, including universal screening and timely access to treatment for all individuals during preconception, pregnancy, and the postpartum periods. A large part of this mission includes collaborating with researchers and clinicians and people with lived experience to support knowledge translation of findings into practice and policy. Over the next couple months, we will be putting a call out because we do want to form chapters, advocacy chapters across each province and territory. And with the amazing success of our second annual fundraiser, Flora's Walk, that occurred the first week of May, World Maternal Mental Health Week, we had over 40 walks across Canada, and the people that, did all the work to establish those walks, to plan them through to fruition. We have such amazing people already, supporting our work and our mission, and we really want to make sure that everybody has the ability to advocate the way that we do. And that's how we're going to create change. And we're really excited to start that new process. So I'm going to pause now for questions. And I'm also just going to thank you in advance. If you would like to connect with myself or Patricia, our email address is canpmhc@gmail.com. And I welcome any questions that you have. And I actually successfully did that presentation in 60 minutes. So fantastic. I'm proud of myself. All right, questions away. I'm going to stop sharing.
That was wonderful. Thank you so much, Jamie. And now we open up for the questions. I do not see anything in our Q&A box here or in the chat box. If you have any question, you can also email me or Jamie later. While we are waiting, I was just wondering about the EPDS screening and the suggestions from the Canadian task force. Did you guys get into any kind of glitches because of that?
Well, what was really interesting is that we're in Canada, we're sending a message that is distinctly different than every other country in the world. So the US Preventative Task Force suggests that every perinatal person should be screened for perinatal mental illness. And in Canada, we're saying, no, don't do that. Just do usual care. And we know that usual care of our clients and people within the community is not including support and awareness and education about perinatal mental illness. And so to say, just do usual care, and to actually suggest that those that are screening to stop screening is really dangerous. And when that recommendation came out, many of our partners jumped right into like instant rebuttals. And we took our time and, made sure that we had the support of our partners across Canada to say, are you okay with this? And if you're not, let's do a joint rebuttal and let's really challenge this recommendation based on very poor quality evidence. And we have another article that's about to be published, but it just felt like we were stepping back in time and that Canada was then being represented in like the Stone Age. And other countries were actually commenting on the recommendation saying, what's going on in Canada? How is that even happening? How could that be a recommendation? So it was very interesting when it came out in, I think, July of last summer.
I agree with you. Thank you for the answer. We have another question here from Ellery. I was just wondering for the SNS of PMH sign and symptoms of PMHDs, how long do the symptoms need to be present for someone to be referred to further assistance?
So we know like the baby blues occur within the first 2 weeks and that, people their mood is quite labile going up and down. We are concerned when the low mood or the anxious state is happening consistently beyond 2 weeks. So beyond that baby blues period. And that's when we want to intervene. So looking at, again, in Canada, we do not have like set scores on the EPDS that says you must intervene here and you're going to need to do this. So people are kind of going to the beat of their own drum. I also suggest it's really important because the EPDS is very depression based, is that trust your spidey senses. If somebody is scoring really low on the EPDS, but has a lot of anxious symptoms, go on to do a GAD-7 or refer them on, because usually your spidey senses are right. Something just seems off. And whenever we do a screen, this is an opportunity for us to be doing health teaching and creating a trusting environment with these individuals and making sure that we are following up. Follow-up is so important. Many of my clients will tell their healthcare providers that they're struggling and will leave with a prescription for, say, an antidepressant, and there's no follow-up. We know that when people take medication, they will need to be followed up, they will need to be monitored, and most likely the dose will need to be titrated upwards over a period of time. So it's really important to make sure that we are following through with our clients. And once we start treatment, it can take anywhere from 6 months to a year for people to have remittance of symptoms. So it does take a lot of extra support for sure. I'm just going to go on to the next question. So somebody was asking if I know of any programs or research regarding dads or fathers. Absolutely. So Dr. Cindy Lee Dennis in U of T, so in Toronto, is doing a lot of research on fathers and partners. We do have a hospital-based program at Mount Sinai and St. Joseph's in Toronto called the Father's Mental Health Initiative, Father's Mental Health Network. And there's 2 psychiatrists there that are doing father-specific mental health support. There's Dad Central, and then many different agencies, like I know the Early On Child Family Center in Aurelia, where I work, they do a lot of fathers programming, like they do different walks and geocaching and different activities to really entice men or partners to come forward, because it is interesting. At my support group on Monday, somebody was talking about how their husband is, really depressed, and, what can we do to provide care for them? And it is really hard to do. So, somebody was just kind of laughing, saying we need to like have a barbecue and like put all the guys in the corner and actually have meaningful discussions about what their parenting journey is like, how they're coping, and how they're supporting. And somebody was actually saying, their husband talks with his guy friends all the time about parenting, and they would love to see what the text messages say, like, what is their view, and how are they supporting each other, and is it a reassuring and validating responses that they are receiving. But definitely we need much more fathers' mental health anti-stigma campaigning and programming in Canada for sure. Next question. It seems to me that the pendulum has swung too far. I agree. Well, tool-based screening may not show the results we anticipated, the data also showed the importance of how questions are asked and the need for a trusting therapeutic relationship when we are doing screening. 100%. I kind of talk about the fact, like when you go and you speak to your family doctor, how many times is it like this? They're on their computer and they're going, how are you doing? How are you feeling? Great, wonderful. And there was never eye contact. There was never that serve and return relationship where we're locking eyes and we're knee to knee, and there doesn't feel to be like a time component to it. And so even just asking, is there anything you'd like to tell me about the thoughts that you're having or the feelings that you're having? How are you coping? Simply asking like 4 questions, like, are you coping? Are you eating? Are you sleeping? And are you enjoying yourself? Those 4 questions create, typically, looking eye to eye, create an environment where people feel like they can trust to say the difficult things, like, I'm not enjoying myself. This is not fun. I haven't slept in weeks. I don't eat until 5 o'clock at night. And those are all things that we need to be intervening about, because if we're not eating, we're not sleeping, and we're not taking care of ourselves, we're not going to have positive mental health. And kind of what I said at the beginning of the presentation is that, if we're as a society telling moms that they can't take breaks and that dads don't have to get up through the night to feed babies, and different messaging like that, we are going to continue to fail, and we are going to continue to have parents that feel like they aren't hitting the bar, that feel like if they take a break, that means that they can't do it themselves. If they're calling to ask their moms or dads for support, that they can't do it on their own. So we really need to be challenging those statements and ideals for sure.
There was a question in the chat box about, are there any triggers for perinatal psychosis?
So perinatal psychosis, more often than not, is caused by untreated or undiagnosed bipolar disorder. People that are bipolar or really severely anxious are hugely susceptible to sleep deprivation. So we really need to make sure that we are watching them through their pregnancy and in those early postpartum days, and supporting them through the night, maybe helping with sleep support programs, making sure that they're on their medications. There's another piece that I can't remember, and I was actually trying to Google it quickly, but couldn't find it. There is research coming out, or it just came out, on complex medical conditions also being triggers to postpartum psychosis. And that's definitely what we saw with Flora Babakani, with, a lot of medical issues in the postpartum period that could have potentially triggered a psychotic episode. And so definitely bipolar, more often than not, is what's causing postpartum psychosis. But for some people, there's absolutely no correlation to pre-existing mental illness or medical complex situations. So sometimes it can just happen. And like I said, because people come in and out of the psychotic state, it's really, really hard sometimes to be able to differentiate what's going on. I actually had somebody in my office a couple months ago who, her mom called me to assess her, and she came in, and it took about 20 minutes for me to identify and to build a trusting relationship, but she was pleasantly psychotic. She was wonderful, doing a really good job, but then kept, saying, oh, you're going to think I'm crazy. And then she would tell me the most bizarre story I've ever heard. And she was very untrusting and very scared that something I said was going to impact her mothering journey or cause apprehension. That's one of the biggest things, is our perinatal moms and birthing people and fathers are afraid that if they divulge information that we will take their babies away. So really making sure that we're having conversations with our local child protection agencies, having them speak at different events about the positive supports that they can provide families in the pregnant and postpartum time period. And that a lot of the time, with proper supports and a potential inpatient stay, babies don't have to be apprehended, even if mom is psychotic. So it's very important that we, pull away from some of those the messages in the community and make sure that we are supporting families with appropriate messaging and all of that. Any other questions?
I saw somebody raising hand.
Can they do that?
Jocelyn, do you mind putting the question in the Q&A? And Kit. There is a comment on the chat box. Charmaine shares your pet peeve about label of the postpartum period as being postpartum.
Mm-hmm. Thank you, Charmaine. I know. There's certain things that you're just like, my goodness. And I heard my mom say it the other day. Oh, yes, there was an article in the magazine about somebody that had postpartum. I'm like, Mom, if I can't get you to say the right thing, how am I going to make an impact through the community or nationally? And she's like, oh, yeah, I know. So it's just really important that when we're talking about perinatal mental health disorders, perinatal mood and anxiety disorders, I know there's not one common piece there, but that we are using common language, that we're talking using the same terms and the same evidence and the same research, because when we have one unified voice, it's going to have a tremendous impact in the support that we're able to provide. Question, how do we build maternal, oh, hold on. I think that's in the chat. It came up and then went down. How do we build maternal communities where moms can find support from each other like the old days? Oh, Brenda, absolutely. I think what we really need to be doing again in our messaging is talking about how important it is that we are not parenting in isolation, that our brains, our culture, our well-being is supported when we parent together, when we parent with other people, when we surround ourselves with people that are like-minded or people in the same area that we're in. So, if it's your first baby, your second or your third, who are the people that you're going to be able to pull into your circle? So really knowing in your community what exists. So for example, in Aurelia, so it's a town of like 30,000 people, just above Barrie in Ontario. And it has just exploded with different perinatal services. So there's a new fitness person that's doing postpartum stroller fitness in different groups. There's a yoga studio that's doing postpartum support groups. I run a group, and that group is run by different people throughout our region called the After Baby Group. So a mental health specific group that is talking about the struggles that parents are having with their mental health. Knowing who the specialized practitioners are within the community. So who you guys can Google the Postpartum Support International Provider Directory and type in where you live in Canada, and everybody that's trained, as long as they've signed up on the list, will come up, and then you go out and have coffee with them, meet them, so you can vet them before you refer them to your clients. Making sure that we're really close with our CAPC and CPNP programs and our HBHC programs through the public health unit. The people within the community that are doing these home visits. And one of my suggestions would be is if you don't have a task force or a perinatal mental health network or women and children's network in your region, start it. Okay, find out who the people are providing the perinatal care within a stone's throw. Get together and talk about ways that you can come together and prioritize perinatal mental health. It's a lot easier when everyone's at the table, and then you don't feel so alone, because it is hard at times when you have somebody that's just crumbling in front of you and you're like, I don't know where to send them. I literally had somebody through COVID that lived off grid. It was the middle of winter. The road to her home was closed. She didn't have internet. She only had cell reception, and literally without, now of course I'm forgetting the word, droning me in and dropping me or a healthy baby, healthy child nurse into her house, there was nothing I could do. Besides having conversations with her on the phone to help her work through how she was thinking and feeling and trying to make an impact on her behaviors. So sometimes it can feel like very helpless, hopeless work, but when we come together and we work together and prioritize mental health within the community, you will have an impact. It might be slow, but I would really suggest, creating those networks. They're so powerful. And come work with us at CPMHC. We need people to help us advocate and prioritize all across Canada and in each province and territory. So cpmhc.ca, and there's going to be 2 really fantastic call outs that are coming out soon. So keep an eye on our social media channels. We're on Facebook, Instagram, Twitter, and LinkedIn. Any other questions?
I do not see anything here. I do have one thing before we end this webinar. So in Saskatchewan right now, the Saskatchewan Prevention Institute is also conducting a brief survey to gather feedback about the resource and information needs of Saskatchewan service providers related to perinatal and maternal mental health. If you provide services to pregnant people or mothers or their families, we would love to hear from you. And I will provide a link to the survey in the chat box here. And it would be great if you could complete the survey and share it with whoever may be interested. And we can definitely share the findings with everybody as well. Thank you. Okay, thank you for sharing that, Jody. Okay, anything else? All right. Thank you for your presentation and sharing your knowledge today, Jamie.
Thank you for the invitation.
Sure. We can all certainly agree that we'll be able to apply the knowledge and information that we gained in our individual fields. And thank you to our audience as well. So when you close the window, you will be directed to a link where you can complete a short survey evaluation of this session. Completing these evaluations helps us to create programming and resources that support you in your work, and we appreciate the time it takes to complete them. So thank you for everybody again, and have a good rest of your day.